Good afternoon, everyone. And we are now starting the session on surgical retina on day 3 in Hall B. I am chairing the session. With me, I have Dr. Hemant Murthy as co-chairman and Dr. Guru Prasad as moderator. We have lined up a series of lectures on surgical retina, and I request Hemant Murthy to start the proceedings.
Thank you, Dr. Muralidhar. So, first of all, it's my pleasure to introduce Dr. Muralidhar, who will be our first speaker. He'll speak to us on recurrent retinal detachments with PVR. Dr. Muralidhar is the president of Retina Institute of Karnataka in Bangalore, and he's probably the senior most retinal surgeon in Karnataka. I think everyone knows him. I would request him to give his talk.
Shall I share the video?
Yes, please, Amma.
Thanks.
Good afternoon. I thank Dr. Ilan Kumar and KOS of Office Bearers for asking me to give this talk. I am going to talk on management of recurrent PVR causing redetachment. We know that PVR continues to haunt us and is the chief cause of failure and resurgeries in retinal detachment. Whenever we are faced with a major revision surgery for recurrent detachment, some decisions have to be made. When to operate? Often we are faced with a situation where few weeks after a successful surgery, patient develops a redetachment due to PVR. If it is in the periphery, not involving the macula, it is better to wait for some more time for the PVR process to settle down and the membranes to mature, at which time surgery will be easier and the results will be better. If the macula is detached, then it is better not to wait but proceed with the operation. If the patient has not undergone scleral buckling, you may want to put a scleral buckle as a part of revision surgery. We will discuss this in a short time from now. What tamponading agent should we use? Because most often we have to do vitrectomy to repair a detached retina due to PVR. My rules are like this: if there is a scleral buccal eye that has got redetachment due to PVR, I will do a vitrectomy and I may use gas if it is a mild PVR. If it is a PVR following vitrectomy and gas, I'll definitely switch over to oil. And any PVR under oil always needs resurgery with oil. Some situations we may decide to do sub-silicone oil surgery. We will discuss this. Management of lens becomes important whenever there is an anterior PVR in a phakic eye. If it is severe, we may have to sacrifice the lens in order to tackle the severe anterior PVR. However, in a pseudophakic eye, you may not remove the IOL in all cases, but can manage to do tackle the anterior PVR in most cases without needing to remove the IOL. Scleral buckling is often resorted to whenever there is a severe anterior PVR. It can be an adjunct whenever there is an unrelieved traction, especially inferiorly. In a phakic eye where you don't want to really do an aggressive vitreous-based dissection, scleral buckling or an encircling could be an option. We use either 240 band when we need a mild indentation or a 42 band when we need a broad support in our cases. What are the steps of revision vitrectomy? We use a 25 gauge atrope, remove the oil, do any more vitrectomy as needed. The most tedious and time consuming step is identifying and peeling the membranes. If there is a vitreous based pathology, we have to address that. We may have to remove subretinal bands if required. We often use PFCL to stabilize the posterior retina if there is a lot of membranes in the periphery in a detached retina. So once the membrane surgery is complete and vitreous-based surgery is complete, we can flatten the retina with PFCL or air. If we have done retinotomy or retinectomy, I would prefer to use PFCL. Otherwise, fluid air exchange is a good test to see if all the traction is removed and the retina is flattened. In addition to endo laser to retinal breaks, I also liberally treat the periphery all round with 360-degree laser in most of my cases. And then we use a preferred tamponading agent, gas or oil. This is a video which shows one of the simplest membranes to remove in a posterior PVR. This video is borrowed from Dr. Guru Prasad. This is a membrane which has caused a pucker and detachment in the posterior pole near the disc. We find edge of the membrane and we grasp the membrane, and it comes off quite easily, separating from the retina. But it's important to make sure that you remove the membrane by a posterior to anterior traction, and you remove most of the anterior extension of the membrane as well. So this is a relatively easy membrane surgery. However, in this case, you can see that the membranes are quite thin, flimsy, wisp-like, and often invisible. And they can really be challenging to remove these membranes, identify and remove these membranes. And I'm using a pick to create an edge and probably identify areas where membranes are present. And it is not uncommon for breaks to occur at this stage because you are operating on a detached retina which is mobile, and the membranes can be firmly adherent. Sometimes around the break the proliferation occurs and keeps the break open, or causes a redetachment due to the open break with PVR. And here I have switched over to bimanual surgery because here the retina is very mobile and the membranes are a little bit more firmly attached to the retina. So we may need to switch over to bimanual surgery in the periphery and whenever there is a detached retina and it is difficult to peel the membranes. So once this membrane peeling is done, if no subretinal band is there, then we can go ahead with the fluid air exchange. Most often we can use a pre-existing break. It's not necessary to create a retinotomy in these eyes because we would have created some break somewhere. So drain from the most posterior break, and if the retina settles down nicely and flattens, that means you have relieved all the traction, and a liberal laser to the breaks and the periphery is done before tamponade. Now, this eye has proliferation in the periphery causing recurrent detachment with open breaks. As you can see here, it also has a macular pucker, although the posterior pole is flat. Now, first, what we have done here is we have tried to remove the macular pucker first, and we have used a brilliant blue to stain the ERM and the ILM. So brilliant blue stained ERM ILM peel is done first in the posterior pole in this eye, and then we go on to tackle the peripheral membranes. Here the peripheral membranes proliferation was thin, wispy like, and I have put PFCL to stabilize the posterior retina here, and the membrane was not easy to detach from the mobile retina. And at one point of time we decided that this retina is too stiff and it is difficult to really peel all the membranes and make it really less stiff, and therefore we decided to do a relaxing retinotomy and retinectomy. So I am doing diathermy to the area of retinotomy, and once diathermy is done, the anterior part of the retina is removed using a vitrectomy machine. And it's important to remove all these anterior redundant retina in these eyes so that it does not cause proliferation at the vitreous base later on, and sometimes it can cause hypotony because of proliferation and ciliary body detachment. And once you have done relaxing retinotomy and retinectomy, we inject PFCL slowly to see if the traction is relieved. And once the retina settles down nicely under PFCL, as you can see here, the endo laser is done to all the breaks, and then fluid air exchange and silicone oil is done. Subretinal bands need not be removed in all situations. Only when they are causing elevation of retina, like in this eye, they need to be removed. Many of them can be left alone if they are not causing traction. Now I have put PFCL to stabilize the posterior retina, and then I made a retinotomy in order to remove that subretinal band. We use a forceps, either end gripping or an ILM forceps, to grasp the membrane. and pull it out. I often use the light pipe like what you see here to push the retina back and get the subretinal band and try to tease it out of the subretinal space using the light pipe as a second instrument. So you can see that I have used the light pipe as a second instrument to pull that part of the band, and I'm trying to remove this other part of the band. I realize that the force can be applied better if I switch my hand. So I switch the forceps to the other hand, and I'm trying to remove this band. These bands are often elastic, and they uh, look easy to remove, but sometimes they are very slippery and they may not come easily. It is better to use a end gripping forceps than an ILM forceps, to remove these membranes. So after deciding for about 5 minutes, I realized that this is not going to work, and I switch over to bimanual surgery with a chandelier in place. I'm using two forceps here, and then with that, what we are doing is a hand over hand technique, pulling the band and then grasping it, and again pulling it and re-grasping it. So this way, with the bimanual technique, we are able to remove the band. So in case of difficulty, do not hesitate to use bimanual technique to remove subretinal bands like this. And once the subretinal bands are removed and all the membranes are removed anywhere else, then we can do fluid air exchange and proceed with tamponade. Subsilicon surgery, wherein you retain the oil, put two ports and remove only the membranes. This is done only if there is a very localized proliferation, because we cannot identify and remove all the membranes in this situation, and it is difficult to get the retina flat on the table. So whenever there are few membranes like a macular pucker under oil, and you don't want to remove the oil and you don't want the macular pucker to cause distortion of the macula for a long time, then you go in and remove only the macular pucker and come out. And obviously it is faster, but applicable only for limited situations. Well, results of surgery for recurrent RD are definitely not that great, but after a pneumatic retinopexy and failure, definitely the success rate is quite good. Most studies show 100% success. Recurrent RD after scleral buckling seems to have better results compared to recurrent RD after vitrectomy. We got about 89% success rate in this situation versus 34% in post vitrectomy or RD under oil, with one surgery, and 66% after multiple surgeries. So PVR continues to be a sobering kind of a situation for most experienced vitreoretinal surgeons. So in conclusion, PVR is the commonest cause for recurrent RD. The timing of surgery is still controversial. Membrane peeling with trace-based dissection, retinectomy, and subretinal band removal are some of the major steps. Adjunct scleral buckling can be a useful adjunct in some given special situations. As of now, we don't really have a pharmacological agent that can help us to fight this vexing problem. We are trying methotrexate intravitreally at the end of surgery, and we are continuing the study. Maybe in a year or two, we will be able to tell you our experience with this. Thank you very much for this opportunity.
Thank you, Dr. Muralidhar, for this excellent talk. As usual, you've stressed on all the important points that are involved in PVR surgery. I think you did mention about the importance of when you would do subsilicon oil surgery, and how should one remove the subretinal bands. You have to take care on the direction of the pull, the instrumentation, about the grasp and re-grasp. I think these are excellent points to, for the youngsters to catch on. There are some situations wherein I think I also do bimanual for membranes of PVR, because sometimes that tends to be a little easier in addition to removing bands that you showed. Any thoughts on, have you ever tried steroids in when you do large retinectomies? I think there was one video by in one of the ASRS, wherein they showed that he leaves the steroids, triamcinolone, at the edge of the retinectomy. Have you ever tried that?
No, I haven't really tried that. No. I know some people are using it, but I haven't really had any experience with that.
Anyone else has any questions? Otherwise, we'll move on to the next talk.
Sir, shall I share the second video?
Yeah. Murali, you have to unmute.
The next talk will be by my co-chairman, Dr. Hemant Murthy, who is also needing no introduction. He's the director of Retina Institute of Karnataka and my colleague. And he's also going to take over as president-elect of Karnataka Ophthalmic Society in this year. In this today, he is now the president-elect and a well-known, very renowned vitreoretinal surgeon. So he's going to talk to us on diabetic vitrectomy, PRD and GRD tips and pearls. Thank you. Over to you, Hemant.
First of all, I'd like to thank the Karnataka Ophthalmic Society and Dr. Ilan for giving me this opportunity. I would be speaking on diabetic vitrectomy, 7 tips and tricks for a successful outcome. Currently, we have fine gauge probes, especially in the 25 and the 27 gauge with the bevel cutter, with its opening closer to the tip, which enables a good dissection of majority of membranes. And you could use a hydrodissection to clear these membranes. So the cutter seems to be adequate in most situations. As you proceed, the second point would be, as you proceed, control the bleeding. Otherwise, the blood clot behaves like another membrane and becomes very difficult to remove. It is very sticky, and by trying to remove the blood, a lot of times iatrogenic tears occur. So you need to control the bleeding as you proceed. The best way is dissect an area. If there is bleeding, first control that and then proceed. Bleeding that occurs at the disc, you can leave a clot. Don't try to remove that clot, because if you remove that clot, it is going to produce a lot more bleeding. Here also, you can use the proportional reflex to clear the hemorrhage. The third tip is use scissors dissection. Here you can see that I first identify the cleavage plane using a pick. The secondary membrane actually extends far beyond that visible edge that you see. And then you can start dissection with the scissors also. I show you how elegantly you can dissect this membrane. This is a broad-based addition. So having identified the cleavage plane, I use the scissors to proceed. And cut all the points of addition that are present. This way, the scissors is a very efficient dissecting tool. And you could safely dissect this membrane without having any iatrogenic tears. The fourth point is, do not hesitate to convert to bimanual dissection. So if you have a broad-based addition, try to change over to a bimanual dissection. Here you can see that there is a broad-based addition, and it is along the arcade And I use a scissors to dissect this membrane. You can also spare the larger blood vessels by doing this. And you can remove this membrane in total. After clearing the hemorrhage in a patient of non-resolving vitreous hemorrhage, stain it with triamcinolone and identify these ERMs that are present at points of proliferation. Because if you leave them, this would provide a nidus for further proliferation or a scaffold for further proliferation and rebleed following successful vitrectomy. And another reason for rebleed is vitreoschissis, which is pretty common in diabetics. Here you can see that I have cleared the hemorrhage in a patient of non-resolving vitreous hemorrhage. And on staining with triamcinolone, I can see the vitreous cortex is present. I identify the vitreous cortex and use the cutter to remove this vitreous cortex to the extent that we can. If I had left this alone, there would be a chance for rebleeding in these patients. Resurgeries are difficult in diabetes, and here one can see that the membranes have not been removed and silicone oil was placed in the only eye of the patient, and patient came back with resurgery, redetachment, and I had to dissect all these membranes. Dissection of membranes when you're doing resurgery is extremely difficult because of the friable nature of the retina. So I first identify the cleavage plane with the pick, and then I convert to a bimanual dissection. This is the safest way to ensure that you don't produce any traction on the retina and thus avoid iatrogenic tears while dissecting this membrane. One has to be very gentle with these membranes because any additional traction, the retina would just tear along and then it would be inoperable. I remove all the cleared membranes. So in conclusion, I can say that you can use these tips and tricks in management of fractional retinal detachment and in patients of non-resolving vitreous hemorrhage in diabetes. When you're dissecting membranes in diabetes, the status of PVD will decide whether you want an inside out or an outside in approach. Always try to identify the cleavage plane. You can do a majority of patients, you do the dissection with the cutter alone. But in difficult situations, try to change over to a bimanual dissection or use hydrodissection to help you during a surgery. Pre-op anti-VEGF and wide-angle visualization have increased the success of surgery. And always try to control bleeding as you keep dissecting the membranes. Thank you.
Thank you, Hemant. With your vast experience, you really, kind of distilled the seven pearls, that we need to follow. One question I have for all the panelists, just a quick question. In which situation would you use anti-VEGF pre-operatively? What is your indication? Just one quick by everyone, if you could just answer that question.
I use anti-VEGF when I find that the vascular element is greater than the glial element. So if I see a lot of vascularization is one situation, a non-lasered eye is another situation. In these situations, I definitely use anti-VEGF.
Mahesh?
In addition to what Dr. Hemant mentioned, I would probably use it in combined retinal detachments because it becomes a bit difficult to manage the bleeders in combined retinal detachment. And pre-surgeries, probably I would use the anti-VEGF a little bit more frequently.
Re-surgeries, okay.
Yes.
Sunil and Krishna, can you?
Basically, non-laser eyes and resurgeries and any high risk cases are probably very high risk of bleed and patient is on anticoagulants or anything. Probably in those scenarios, I will use it.
Krishna?
Yeah, largely when the vascularity is pretty troublesome, you would expect that you will have a tough time going through that. So largely dependent on the vascularity more than anything else.
Okay, that's good because I'm glad to know that nobody is using it as a routine in the pre-operative period. And I think Hemant stressed on use of bimanual surgery in spite of the cutter advances in the technology and all that. Still, bimanual surgery has a definite role. And I think we are running short of time. If any single comment from anybody else, then we go on to the next lecture by Dr. Mahesh Shanmugam on ROP.
Shall I use? Sir, shall I
You can just
video?
start sharing Dr. Mahesh's this one presentation. He's going to talk to us on surgery for ROP. Dr. Mahesh Shanmugam needs no introduction. He is a well-known figure in the vitreoretinal surgery. He is currently the head of vitreoretinal and surgical oncology, ocular oncology at Shankara Group of Institutions, Bangalore, and well-respected and a very renowned person. He's going to talk to us on ROP surgery. Mahesh, over to Mahesh.
Let's look at the role of vitrectomy in the treatment of diabetic macular edema in the next few minutes.
I think it's a wrong presentation.
Who underwent multiple intravitreal injections of anti-VEGF agents and steroids, but kept coming back.
Can you please stop the video? Can you please stop the video?
Presentation.
Carefully.
No.
And found that there was epiretinal membrane.
Can you stop the?
There is a vitreomacular interface disorder in diabetic macular
Excuse me.
edema. They may respond initially, but they may respond suboptimally. In such a situation,
Team from Abhinava, this is not the video for this session.
This is not the video for the session.
Undergoing vitrectomy.
This is for the afternoon session.
This patient was not.
Abhinava team, can you please stop this video and share the right video?
The epiretinal membrane is not obvious at all. So we
Usha?
need to create an opening, and once we have created an opening, we can see such an extensive.
I don't seem to have the presence of.
Being peeled off, and subsequently we stain.
Can somebody from the Abhinava team
The brilliant
be here?
G and then remove the internal limiting membrane carefully. When we do internal limiting membrane removal in patients with diabetic macular edema, we need to be particularly careful not to deroof the cystoid space, which may be at the fovea. Sometimes one may have.
Can Abhinava team come in?
Internal
I don't
limiting
think they listen. Yeah, that's the problem.
Sunil, you have any numbers of Abhinava team?
I think they.
Sir, I'm trying to call them, sir. I'm trying to call them.
Hello.
Yeah. They seem to have stopped the video now.
Can you stop the video and change the video, ma? This is not the video.
Yeah, Google Drive was the right video. I have seen it. Yeah, why can't they play it?
See, this is a.
This is for the afternoon session. This is for the afternoon session. This is at 4 o'clock.
This video that you put up is at the 4 o'clock one. The other video, which is on ROP surgery, you just
ROP surgery. Okay.
Usha, surgical retina session, Google Drive has the right video. Please play that.
Surgery in ROP. In stage 4, partial retinal detachment.
Is this
now
the
you
one,
go
sir?
back. Go back.
Go back from the beginning, please.
Go back to the beginning.
Yeah.
Yeah.
Perfect.
Okay, sir.
ROP
Thank you.
presentation.
I think you should stay in place, Usha, because we lost about almost 5 minutes
Partial
trying to get the right video.
Yeah, when the
Okay.
extramacular progressive retinal detachment, and stage 4B when it has involved the macula is when we advise surgery. Scleral buckling is an option to treat.
Increase
stage
the
4.
volume a little bit.
What happens is the remodeling of fibrosis results in retinal reattachment. We usually place a 240 band at the highest part of the ridge, and the paracentesis can be done to manage the intraocular pressure. And usually a segmental buckle is not placed. Scleral buckling is possible to do if it's a peripheral disease. And the buckle usually has to be removed lest it impair the growth of. The reported rates of retinal reattachment with scleral buckling is 46 to 70%, but the scleral buckling surgery has been largely replaced with lens sparing vitrectomy because it achieves better visual and anatomical results. As I mentioned earlier, the buckle has to be removed 6 to 9 months later because it may hamper the growth of the eye and can erode into the developing eye as well. Moving on to vitrectomy. So when do we do vitrectomy in ROP? Earlier surgery is beneficial because it can result in the visual cortex development, but then we have to balance this against the infant's general health. The child should be able to withstand anesthesia and surgery. And stage 4 generally we interfere earlier, and stage 5 anyway it's a total retinal detachment with a closed funnel, so we can wait until the neovascularization regresses so that we are able to do the surgery a little bit more peacefully. Lens sparing vitrectomy can be done usually in stage 4A and stage 4B, very rarely in stage 5. Posterior disease helps us do a lens sparing vitrectomy, and peripheral ablation, if it has been done earlier, it makes the life much easier. So here is one of the lens sparing vitrectomy surgical steps which you can see. Sclerotomies are usually placed 1.5 millimeters from the limbus, and it's usually to the pars plicata. I usually prefer a sutured infusion cannula, which is about 2 millimeters in length. People do place trocar cannula systems. I don't place trocar cannula systems because the socket is not very well developed, and the placement of the trocar cannula, we have to exert fair amount of pressure, and there's a possibility of lens damage. The posterior vitreous is not detached completely, and it's irregularly attached in ROP, so we need to identify this, and only relevant areas of traction are to be relieved. So the anterior distal traction, that is the vitreous,
the theme is what lies within, always look for that.
Dissected, and from the ridge to the vitreous base is again an area of proliferation which, if it is possible to dissect, we can dissect. Otherwise, the bridging traction from ridge to ridge, that bridging traction can be relieved. For instance, in this child, the inferior part, there is no posterior vitreous detachment, superiorly posterior vitreous detachment was there. So we relieved the relevant traction, and the avascular retina was treated with laser photocoagulation. In select cases, we resort to what we call as minimally invasive ROP surgery. In cases with a localized area of traction retinal detachment, as in this patient, where the proliferation and traction retinal detachment is essentially nasal, and it is because of one area of the fibrous tissue dragging the retina anteriorly. So this, from the ridge, the proliferation can extend to the lens and also the loop traction. So you can see that the sclerotomy is placed in such a way that the scissors is able to access this area of traction retinal detachment, and this relevant traction from the ridge to the lens and from the ridge to the vitreous base is dissected without doing an extensive vitrectomy with the use of the scissors. So in select cases, this can be done as well. So moving on to stage 5 ROP. The earlier days, people used to do open sky approach, and nowadays we do most often a closed vitrectomy. So this is one patient who is undergoing a vitrectomy for stage 5 ROP. So the sclerotomies are placed about 0.5 millimeters or at the root of the iris, and once a lensectomy is done, an anterior chamber maintainer is placed initially, and once a lensectomy is done, we go around start dissection. Most often it's a bimanual dissection with the scissors and the forceps, starting in the periphery. What we see dull gray below is the retina, and anteriorly the fibrous tissue is dissected with sharp dissection from the retina. So very careful dissection allows us to see that the peripheral trough can be seen, and the dissection progresses posteriorly and all the fibrous tissue is removed. If there is a fair amount of distance in the peripheral trough, then it becomes easy because the trough is deep, and so we are able to insert our instruments without too much of a problem of creating a dialysis. And as we progress posteriorly towards the disc, we may not be able to identify the disc, but we know where the proliferation extends from. So we can see the peripheral trough is open and posterior TRD which is there, which will settle over time. So sometimes in essentially zone 3 disease and zone 2 disease, we may find this falciform fold with traction retinal detachment. One such patient where the falciform fold is highly elevated, so we went ahead with the lensectomy, and one area of fibrous tissue growth from the falciform fold to the posterior capsule is there. So this area of anteroposterior traction is relieved, and that fibrous tissue, which is the one which was attaching the retina to the lens, is dissected off, and the falciform fold is allowed to fall back over time. So as we all know, ROP detachment is essentially tractional most of the time. Very, very rarely it can be rhegmatogenous. So we relieve the traction and allow the retina to go back to its space. So some amount of vitrectomy around the falciform fold is done. Again, the vitreous may be attached in multiple areas, multiple places, very, very irregularly. So only the relevant traction, and as long as much PVD can be created safely, is what is removed. Sometimes in zone 3 TRD, where the traction is extremely anterior, and we may be forced to do a lensectomy, and I would resort to this scleral imbrication, because I wouldn't want to do a lensectomy. And even if with lensectomy, what happens is sometimes the fibrous tissue is integrated into the pars plana, and we may not be able to relieve the traction adequately by going inside. So in such a situation, I shorten the sclera instead of extending the retina. Instead of removing the fibrous tissue and allowing the retina to fall back, we shorten the sclera so that the traction at the falciform fold is relieved and the retina goes back. This can be done in an extremely anterior disease, but despite which there is a falciform fold extending posterior towards the macula. ROP surgery, resurgery generally not preferred, and rarely I do those. And this is one such where the patient the retina did not go back, but developed a lot of pre-retinal proliferation. As you can see, the anterior chamber maintainer is placed, and because we have removed the iris in the previous surgery, and the entry into the eye is through the limbus itself, and a sharp dissection again. All the reproliferated tissue is removed. Sometimes we leave behind tissue posteriorly because we are not able to access it, or we are not able to safely access it during the primary surgery, waiting for the retina to open further before we go ahead with the subsequent surgery. So here you can see that some amount of tissue which was left behind posteriorly is being dissected now, along with anterior dissection of the recurrent tissue, and we leave behind viscoelastic to open up the funnel. And very, very rarely we do an open sky vitrectomy in ROP, and this is one such where the iris was removed and the cataractous lens was removed. We are forced to do an open sky ROP surgery here because the cornea was opaque in this child, and this was the only existing eye of the child. The other eye had become thysical as well. So with the open dissection of the fibrous tissue with scissors and forceps through viscoelastic, and the parallax when we operate through the fluid does make this difficult. It's not as easy as it looks. So managed to remove all the fibrous tissue and used viscoelastic and close the eye. So results of ROP surgery, the earlier we do and lesser the stage, the better are the visual results. So stage 4A, anatomical success quoted is 90%, and visual success, 3/4 of them have some good, reasonably ambulant vision. Stage 4B, around 60% anatomic success, and only 1/3 will have some ambulant vision. And stage 5, anatomic success itself is only in less than 1/3 of the patients, and less than 1/3 have measurable vision acuity. To summarize, surgical management of ROP remains a surgical challenge. Stage 4 surgery, better visual and surgical results. And stage 5 surgery, I will still attempt surgery to see whatever that 1/3 will get some useful vision or not. Thank you very much for your kind attention.
Thank you, Mahesh, for such lucid presentation and very good videos. One question I wanted to ask you in stage 4A or B, how do you decide whether to do a buccal versus lens sparing vitrectomy, or you have given up buccal already now, 240 band already, or what is how do you choose?
More posterior the disease, I do vitrectomy, lens sparing vitrectomy. More anterior the disease, the ridge is anterior, then I tend to put a buccal. It's not as I've given up on the buccal. So zone 2, zone 3 disease is when I do a buccal, but posterior disease, then I prefer to do a lens sparing vitrectomy.
Okay. And is there any role of, we know that anti-VEGFs are being used in managing ROPs in general. Is there a role for any use of anti-VEGF prior to surgery in this situation?
Yes, in case like the laser is not possible, sometimes the children develop vitreous hemorrhage, and then sometimes they have rubeosis iridis also. In that situation, I would probably give an anti-VEGF and then take them up for surgery. Stage 5, yes, if there is rubeosis iridis, I probably give. But the problem in stage 5, there's no space to give anti-VEGF because everything is so anterior chamber is also collapsed. So I would usually wait for the neovascular state to regress. But on stage 4 disease, where I'm probably planning a lens sparing vitrectomy, I may sometimes consider anti-VEGF.
Thank you. Any other comment from anybody else? Want to add anything?
I think.
Thank you, Mahesh. Yeah, Hemant. Yeah.
Thank you, Dr.
I think let us proceed. Thank you, Mahesh, for a wonderful talk. So next is just a second. You have the
Dr. Sunil.
Dr. Sunil Ganekal's talk. Okay.
Yes.
Yeah, uploaded my video. Usha, can you just play my video?
Yes, sir.
Dr. Sunil Ganekal is vitreoretinal surgeon in Davangere, and he is a well-known vitreoretinal surgeon. He is also a visiting ophthalmic professor at Mayo Clinic. Recently he has been recognized and appointed as a visiting vitreoretinal surgeon at Mayo Clinic, and it's all a proud moment for all of us that our own colleague has been recognized and his talents have been recognized, and he has been rewarded with that kind of a recognition.
Thank you.
So, please go ahead with your talk. Yeah.
Good afternoon, everyone. Today I will be regarding vitrectomy for optic disc with maculopathy. In optic disc with maculopathy, spontaneous resolution can occur around in 25% of the cases. Laser alone may not be very successful in many of the cases, so one need to resort to past-planar vitrectomy. PVD induction and gas tamponade are the most critical steps in past-planar vitrectomy. Certain additional maneuvers or additional techniques has to be done intraoperatively, like peripapillary laser, ILM cleaning, fluid aspiration, subretinal fluid drainage, peeling of a glial tissue from the optic disc, intraretinal fenestrations, and the sealing of the optic disc with various tissues like scleral graft, amniotic membrane, and ILM flap. Let me share with you a video of a vitrectomy for an optic disc pit. The vitrectomy is done with a triamcinolone assisted vitrectomy for visualization of the vitreous and for the PVD induction. Do a thorough complete vitrectomy. Do a PVD induction. Once you're done, once continue with the vitrectomy, the PVD induction being done, then you stain the ILM with a brilliant blue dye. Once the staining has been done, you continue with the ILM peeling. If it's a fovea is grossly cystic, preferable to do a foveal sparing ILM peeling. Grasp the ILM by pinch and peel technique. You can slowly and gently peel the ILMs. ILM peeling can be done up to the arcades, similar to the way you do it for the macular hole. So here is the continuation of the ILM peel and enlargement of the peel to the extent possible. So continue enlarging the ILM peel. So staining gives a good visualization of the ILM, and peeling will be very easy after staining with a brilliant blue dye, like any other cases with ILM peeling with macular hole or other cases. So continue with the ILM peeling. So peeling being continued there. So peeled up to the optic disc edge and taken it off. Now you can, whatever the residual ILM thing was there, we can bury it into the pit area, and inverted ILM plug can be used, the flap plug can be dipped into the optic disc pit. And once you have done that, you can do laser to the temporal edge of the optic disc to prevent the closure of the fluid or fluid seepage from the communication tract into the macular area. Once you are done, you can do a fluid air exchange and inject a gas for the tamponating purpose. Sometimes, as I told before, there is a risk of deroofing the macular area but causing an iatrogenic macular cyst. Better to do a foveal sparing ILM peeling than the conventional ILM peeling. Certain additional modifications you can do, like usage of fibrin blue for in case of an optic disc pit. Here, after vitrectomy and PVD induction, brilliant blue staining and the optic, the ILM being peeled. So peel to the extent possible. Larger the peel, it's better. So ILM peeling being continued here. So once you finish with the ILM peeling, you can inject a fibrin glue onto the retinal surface. Once you inject the fibrin glue, it forms a coagulum on the surface of the retina. You need to remove that coagulum form fibrinous membrane from the retinal surface and lift it up and trim it as much to the extent till the area of the optic disc margin. So it acts as a sealant for the closure of the optic disc pit. It is an additional maneuver you can consider in a patient with an optic disc pit maculopathy. Sometimes in cases where this is a case where vitrectomy was done, ILM peeling was not done, but laser was also not done. But scleral graft being used as an ILM plug, the scleral graft is being used as a plug into the optic disc. So the scleral graft, lamellar autologous scleral graft is being put into the optic disc pit. Make sure that while inserting the optic disc, the scleral graft into the optic disc pit, keep a close watch on the pulsations in the disc area, as well as there should not be any collapse of the vessels. You can see on the right hand side, by about around 2 months, there is a complete anatomical reattachment post scleral graft plug in optic disc pit. There's another comparative study published in British Journal of Ophthalmology, which we compared vitrectomy ILM peeling gas was compared with the plugging with ILM and autologous scleral flap. It showed that plugging of the ILM with the plugging of the pit with ILM as well as the scleral graft gives a better outcome than vitrectomy and ILM peeling alone. You can use sometimes you can use an amniotic membrane also for the plugging the optic disc pit. So it is similar to the scleral graft. You can use the this amniotic membrane and plug it into the optic disc pit. Here also the closure occurs very well. You can see on the right side of the picture, this is a 2 months post-op OCT, which clearly shows that the amniotic membrane helped in complete resolution of the fluid in optic disc pit maculopathy. But keep a close watch on the disc pulsation and the vasculature when you are plugging the pit with any of these tissues, either the sclera or the amniotic membrane. Another technique which is very well described is the direct aspiration of the fluid. Here is a case of an optic disc pit with chronic intraretinal fluid and minimal subretinal fluid. Here the vitrectomy has been done with a transinolone assisted vitrectomy being done and the PVD being induced for complete vitrectomy. Once you have done that, the triamcinolone sometimes helps in the complete hyaloid removal, as well as even the part of the ILM can also be peeled under triamcinolone assistance also. So once you peel the ILM and the posterior hyaloid, the next and the most, the additional step we did in this procedure was aspirating the fluid using a 30 gauge cannula. You look at the cystic cavities, and the preoperative OCT will give a guide which is the area to be chosen for the active aspiration with the thing. So choose the quadrant with the maximum height for the aspiration. Use a 30 gauge cannula, go tangentially and aspirate the fluid under active suction. So the puncture can be done at multiple sites. Make sure that there should not be any enlargement of these fenestrated or punctured areas. You can see by 6 weeks, there is a complete anatomical reattachment. The advantages of this technique is, unlike conventional vitrectomy, which takes around 6 to 7 months or 12 months for the complete anatomical reattachment, this technique can bring about results in 2 to 3 months itself, but it carries the risk sometimes. And so probably intraoperative OCT guided aspiration will be better advisable rather than doing a blind aspiration. Then do a fluid air exchange and then put a gas. The sequence of resolution of fluid, the first after post vitrectomy, usually the intraretinal fluid resolves first and there will be closure of communicating tract. The outer layer detachment next closes. The SRF and the outer retinal fluid takes a lot of time, probably may take up to 8 to 12 months for the complete resolution. So vitrectomy, the post-op vision following vitrectomy basically depends upon the absorption of fluid and restoration of macular anatomy. Surgical success is defined as either absence of fluid or decrease in central macular thickness by more than 20% compared to the baseline. Complete restoration is that is absence of both intraretinal fluid and subretinal fluid. Incomplete restoration is SRF being absorbed, but the residual intraretinal fluid is present. Failure is considered when there is a persistence of SRF or increase in the fluid after a certain decrease. Then the visual success is gain of at least 2 Snellen lines over a period of time. The outer layer detachment with extensive ellipsoid zone disruptions gives or indicator causes the poor visual functional outcomes. Increased baseline central retinal thickness and multi-layer schisis on OCT are the poor prognostic factors. These cases tends to do poorly. If communicating tract remains open post vitrectomy, then definitely it needs a resurgery to be warranted. Then in conclusion, the management of optic disc maculopathy remains challenging. Post vitrectomy long-term success is good and results in improvement in visual acuity. It can take more than a year and multiple surgeries sometimes to achieve a foveal reattachment. Adjunctive techniques should be considered in selected cases. Outcome is better as shown by the studies also if the optic pit is plugged. Thank you for your patient hearing. With this, I would like to conclude my talk.
Thank you, Dr. Sunil, for an elegant talk. Just, I want to ask you one question. Do you see any role for doing the laser at the edge of the disc? Because generally, once you plug the optic disc pit, I mean, I have never done it after started doing that. That's why
I used to do it, sir. Now I have stopped doing the laser.
And I see some videos in which you have done,
Yeah, earlier that was the first one was a old video. So nowadays, whatever, I've stopped using it.
Okay. And any other comments from any of the other participants? Anyone?
Yeah, Dr. Sunil was saying that we can aspirate the fluid. It's not easy to aspirate the fluid in many times, and the schitic fluid also it becomes difficult to aspirate.
Yeah, definitely, sir. Because the depth at which we go, probably it becomes a blind aspiration, and complication risk is also very high, sir. That was considered as a long-standing schisis, sir. That otherwise probably may not be considered.
Any ideas to when you will prefer what technique? Because there are so many techniques which you can follow.
Yeah, the adjunctive techniques like graft and other things only in refractory cases are not for the primary surgery as per se. Primary surgery, definitely vitrectomy, ILM peeling and gas should suffice. And suppose a glial tissue is over the disc and peeling that, and if there is a clear-cut communication tract is there, then probably these grafts and other things may work, sir. If there is no clear-cut communication tract, probably I will avoid all these things, sir.
Again, fibrin glue gets absorbed. After it gets absorbed, with the tract not reopen?
Yeah, this early resolution of fibrin is another concern, sir. Probably you need a long-term success may not be good, but only when refractory is there, probably may not work with the primary procedures. Probably all these things can be tried.
Thank you, Doctor. Nice talk.
And the other thing was that nowadays, I mean, I don't do. I always do a fovea sparing. So I think you're also probably doing it nowadays. Earlier, people used to do, but I think nowadays everyone does fovea sparing island peeling.
I agree, sir. I agree, sir.
Because there are late chance of macular hole formation. And initially, you might not see anything. Later, it tends to form.
Yes,
Thank you, Sunil. We'll go to the next talk by Dr. Srinivas Joshi of vitrectomy for large recurrent macular hole. Dr. Srinivas Joshi, the video you can play.
Sir, Dr. Srinivas Joshi's video we haven't received.
I'm here, sir. I'll just play directly. There was some error in this. I'll just play it.
Okay, sure.
I hope my screen is visible, sir.
Yeah, screen is visible.
Okay.
But okay, that's fine.
So I'll be just sharing 4 cases. Sorry, this was again a repeat topic which I presented in the last COSCON also, but I will definitely try to do justice to the topic allotted to me. So this was a case of the recurrent MAC hole where the ILM peeling was done previously, and then the patient was referred for the failed MAC hole. So what we do usually, my first choice in these cases would be to definitely go ahead and do an ILM transplant. So here, either you can do it, I'll show you the technique later on. Either you can put a PFO and try to slide the ILM under the PFO, or better could be put a viscoat inside the MAC hole and then just try to take some free flaps from the area elsewhere, and then you can just try to stuff it inside the MAC hole. And since this was a little larger basal diameter, so I thought I should take a little more ILM after the primary, which one I took it from the other area. And now you can see just an IOCT to just reconfirm it. And then doing a careful fluid air exchange is very important. And fortunately, to my surprise, the patient improved from 660 to 69. It was really a very surprising thing for me as well. So this was the next case, as you can see here. This was the case. He's a police constable and who got hit in the lathi charge accidentally. And here there was a nasal RD as well, and you can see a small thin film of blood under the macula, over the macula. So what I thought was, anyhow I was inside, so let me do a subretinal TPA as well. So I did a fluid air exchange, try to settle the retinal detachment here under the fluid air exchange, and then just lasered it, the retinotomy site. And then I just injected 0.1 ml of subretinal TPA, and a good blister was formed. I thought it will displace well, but unfortunately the patient developed macular hole 2 weeks post-surgery. So that was, I think, a wrong idea to put a subretinal TPA here, or whether it's the traumatic, trauma itself was ensuing a secondary MAC hole later. I'm not sure about it. But here what I try to do again is do a multi-layered ILM peeling. So this was this is just the technique. We have done around 110 cases for now, having 0% of flap dislodgement as described by Mikulivska earlier paper when they described the inverse ILM peeling, showing around 14% of flap dislodgement. So here you can see I just started at least a disc or 2 disc diameters away from the edge of the MAC hole, and just try to pinch and peel it until the edge of the MAC hole. It acts like a hinge. And doing it under PFO, the advantage is it gives a counter traction, so the flaps will not slip away, and it tries to stay inside the MAC hole, and so that it becomes more neat and more clean to put these ILM flaps inside the MAC hole rather than doing without PFO. And just did a fluid air exchange. After doing a fluid air exchange, I put the gas tamponade and the post-op picture, and the patient had type 1 vision. At least around 2 line Snellen visual improvement was there in this case. So this is another case where I have even done macular detachment inductions in the failed primary MAC holes, where the ILM peeling was done. And here So first, this was the case. This was a small hole. I could have just teased it, but it did not. So I had to go ahead and try to do something else, is try to release the traction at the edge of the MAC hole to the RPE and create a little bit more elasticity of the retina surrounding area, so that when you tamponade it, it gives a good break. This was a technique I followed through my senior colleague from University of Toronto. He has published it around 10 cases using a 42 gauge syringe causing a macular detachment induction. And he has shown around 9 cases of success. In my 4 cases, 3 were successful. And this was the 4th case. I'll be showing it here. I tried to induce a macular detachment in all the 3 quarters. However, some surgeons have tried even the papillomacular bundle, but I don't want to disturb the PMB area. And definitely, as you do a fluid air exchange, because of the gravity, the velocity comes up, and then the aim here is to completely lies the 360-degree attachment. But unfortunately, in fact, the hole size increased. And the only attempt left to me here was to do autologous retinal transplant graft. So here what I did was, this is just like a routine, cauterize the area, and either you can do it over the MAC hole, to just take the graft using the chandelier bimanual surgery, try to cut it and try to cut it inside so that you don't take the burnt edges from the cauterized side. And either you can just slide it under the PFO, or you can put a PFO over it. But nowadays I'm trying to slide it. It is pretty much easier, which I'll be showing it in the next video. So I just did a laser over the retinectomy area and the IOCT confirming the graft placement, and did a fluid air exchange, and the silicone oil tamponade was given. And finally, the MAC hole closed successfully in the 3rd attempt, and the patient has around from 3/60, she has improved to 6/36. So this is my next and the last video. Here the patient had been operated for a traumatic endophthalmitis, but later on he developed a MAC hole, and I thought I could do an ILM peeling, but I think I was traumatizing more retina here, so I could not do an ILM peeling in this case. So what I tried was to do a neurosensory graft in this case as well. So I put a PFO. This is the recent video, just 1 week back I operated on this case. And here I think you have a Ingenuity. If you have it, you have a luxury of using different colors. Now you can see I'm just sliding it under the PFO. And then when I put the IOCT, I could see a small PFO bubble underneath the graft. I think you can see it clinically also. So I just took out, slided that, and now you can see that PFO bubble there. So I just removed it through the extrusion needle, and there was a pretty much of puckering here. So I thought I should release this pucker. Probably this pucker itself probably could have caused the MAC hole in this case. So I just released the pucker, and then I just slided the graft back to its position. Unfortunately, the graft size was pretty much in the optimal size. And this is just 1 week. So I just took a OCT photograph, but I forgot to put it here. It shows a good graft integration in this case as well. So thank you very much for the patient listening.
Thank you, Srinivas. As usual, very nice, beautiful videos. I think in the last video, the bubble of PFCL helped you identify the other membranes. Otherwise, you would have had a problem in hole not closing, because those were the causing the tangential traction.
Exactly.
So that was one. The second, I just wanted to ask you, in the patient in which you use the autologous graft, you said I put silicone oil. Any reason why you choose that?
Only if the patient are not compliant with the positioning. So what happened was, it was a young patient. I thought he will position well. I put the gas to him, and next day I see is the graft moving away from the area. And what happens, another thing, if they don't maintain the position well, the fluid gets accumulated, and that itself might dislodge the graft again. So that's why it's always important to do a continuous prone position, especially until the initial few days is very crucial. If they are not compliant, I would definitely go in a safer procedure to put an oil. In fact, after putting the oil also, sometimes we see the graft moving. So what I do is I put the oil, check again whether the graft is in place. Otherwise, I just try to adjust it and do that. Only in few cases it moves, but most of the cases, the graft stays well.
Okay, Pa. Thank you. I think we'll move on to the...
Srinivas, I have a question for the case which developed a iatrogenic macular hole post-TPA. Is it advisable? I want the opinion of the other panelists also, injecting TPA.
No, I don't think so, sir. I burnt my fingers in this case. I don't think, because that was just a thin film of blood. And since he was the police constable, he was very much behind me that do the best thing. I just want to get that blood out and everything. He had read the internet, and he had read that clearing the submacular hemorrhages, subretinal TPA. So probably I got tempted and I was influenced by his thing. And definitely I myself, after this video, I would not recommend for this such a small thin film of fluid. But definitely if it is covering up to the posterior pole, or how the apois, this thing, or many classifications have come, which says the more than 4 disc diameters, if there is a thick blood, I think in those cases we can definitely try a subretinal TP.
Okay.
Thank you, Pa. Thank you. I think we'll move on for paucity of time. Murli?
Yes, next talk is by my very close friend, Dr. Guru Prasad. Dr. Guru Prasad again is one of the senior vitreoretinal surgeons and needs no introduction. He is the chief of vitreoretinal surgery at MM Joshi Eye Hospital, Hubli, and has a vast experience of vitreoretinal surgery in the northern part of Karnataka. And he was also the past president of Karnataka Ophthalmic Society, and has been awarded the Bhujang Shetty Oration in 2019. And his videos again are very good, and he has a number of very difficult foreign bodies which he has removed. He's got videos, and today again he's going to share the experience of his tackling of intraocular foreign bodies. Thank you, Guru, for your presence here, and I request Usha to play his video.
Right. Thanks to the KOS, especially the scientific committee, for this opportunity to be part of this wonderful symposium on surgical retina. I'll be speaking on intraocular foreign bodies. The first step in the management of a foreign body is the diagnosis. One has to suspect a foreign body and diagnose it. Localization comes next. Characterization, whether it is metallic or non-metallic, is also very important in the management. And then finally, the management and its removal ensues. So the telltale presentation of foreign bodies, usually of an intraocular foreign body, is usually present, but sometimes we have to take a detailed history of a metal on metal activity, especially a subconjunctival hemorrhage, a wound of entry, a hole in the iris, a cataract which is localized, or a track in the vitreous is something that should draw our attention to the presence of a foreign body. And this is the typical sclerotic long-standing foreign body changes that occur in a patient with a foreign body lodged for several months. This is a patient of a young patient who had recurrent vasculitis and vitreous hemorrhage, was treated with steroids and after a uveitic workup, but we did not suspect a foreign body because we did not. The mistake that we did was that we did not examine this child under GA. All that we had to do was to raise the upper lid and look for this track in the lens, the hole in the iris, and of course, ultimately the end result was good. So we have to have a high index of suspicion in all cases of trauma for the presence of a foreign body. This patient was referred for penetrating keratoplasty after primary suturing and cataract removal. Imaging showed a large foreign body with retinal detachment, and this foreign body was as big as this, needed an intracapsular extraction type of incision to remove this large foreign body which was embedded in the ciliary region. So the first challenge itself is diagnosis. So rule out foreign body in every case of penetrating injury. Confirmation and localization is another thing. X-ray was the gold standard during our days when we were residents. Ultrasonography soon followed. The persistence at lower gain, especially for non-metallic foreign bodies, and the 3D imaging is now possible with the ultrasound. The limbal ring or contact lens was being used to sort of keep it as a reference to know how far the foreign body and at what point in the foreign body is located. CT scan is the gold standard. MRI is also very useful and should be used for wood and plastic, but definitely not for metallic foreign bodies. But before cataract formation, before dispersion of vitreous hemorrhage, before vitritis sets in, one important tool that we have in our armamentarium, a simple one, which gives invaluable information about the presence of a foreign body and its location, is the indirect ophthalmoscopy, and one should spare no efforts to look for one, even if there's a mature cataract. So this is one example of a challenge on hand with an open wound of entry. Foreign body is there. In any patient, there can be a cataract with PCR, there can be infection, there can be vitreous hemorrhage and retinal detachment. All of the above may be present in a given patient. So the management, restore the globe integrity, infection prophylaxis is something that we have to observe. And then the surgery for removal of the foreign body and vision restoration. The comprehensive ophthalmologist has an important role to play. Let us see one example. So this is a case of a foreign body that has gone through the central part of the cornea. Suturing is done. There's a small incision is made to remove the exudates from the anterior chamber. The cataract is evacuated, and we have a clear glow. So one can look at the fundus, see the foreign body, make a drawing, and send the patient to the PR surgeon. This is another patient who was asymptomatic 6x6 trivial trauma, lead injury. And then when we averted the conjunctiva, we saw that there was a subconjunctival hemorrhage which was harboring a sterile tear, which we had to look for and suture. So repair of sterile wound of entry can be done by the comprehensive ophthalmologist. So even if the patient is asymptomatic and even if the vision is good, one has to look for these sites of entries of the foreign bodies in any trauma case, especially when it is penetrating trauma. Whether an IOL can be implanted in these patients is another question that the comprehensive ophthalmologist asks. And if the surgery can be clean and if this inflammation can be suppressed, I think it is a good idea to implant an IOL and suture the wound so that the vitreoretinal surgeon has a better wound integrity at the time of his intervention. But the cutoff would be probably 3 millimeters in size. If the foreign body is more than 3 millimeters in size, then better not to put an implant, because the foreign body sometimes may have to be removed from the limbus transpupillarly. This is another challenge of a young patient with a large foreign body. There's no PVD, the lens is clear, but eventually during the surgery becomes hazy. The view is hazy throughout. The edema of the retina is there, making it very friable, and therefore one can do a limited vitrectomy. And if it is possible to see the foreign body, we can remove it by magnetic means, as shown in this video. The foreign body comes out easily with a limited vitrectomy after freeing it from the rest of the vitreous. And once this is done, a second surgery can be performed later when the inflammation is down, and the vitreous can be cleared of all the vitreous debris, where it amounts to just an optical vitrectomy. So a two-stage surgery is also prudent. Sometimes the foreign body seems to be lost in the vitreous cavity, and usually when we indent the inferior retina, it is possible to get these foreign bodies, because that is where, because of gravity, they would have settled down. And with indentation and a little vitreous base excision, it is possible to see these foreign bodies and remove them. These are two examples of foreign body, one right at the macula and one near the macula. You can see this is right at the fovea. And one has to be very, very careful. They are very, very heavily encapsulated by fibrous tissue, and one has to be extremely careful not to damage the parafoveal area. And this is another foreign body which is close to the fovea. The patient has 6x6 vision, and this again, by teasing the foreign body out of its capsule, it is possible to remove these foreign bodies without damaging the fovea. The firm encapsulation is something that is almost universal. Within 2 days, it is possible that the foreign body could be encapsulated. Pre-op laser, whenever possible, whenever the media permits, is something that I practice. And if the foreign body is quiet and if it has been there for a long time and there's no infection, it is possible to, it is probably advisable to do the laser around the foreign body site and then resort to surgery a few days later. Laser during surgery is something that is inevitable and has to be done at all sites, at the site of ricocheting, at any site of a tear. And this is best done before PVD induction, because during PVD induction, sometimes the retina can be lifted and laser becomes difficult. The limbal route is something that I prefer for foreign bodies that are larger than 3 millimeters in size, and also for non-magnetic foreign bodies, because sometimes we have to resort to certain methods like this. As you can see in the video, this was a stone particle in the vitreous cavity. After vitrectomy, it was not possible for it to be held by any means. It was not possible for it to be floated up by PFCL, and therefore we had to resort to a vacuum extraction. It was held with vacuum, a powerful vacuum with extrusion needle, soft tip cannula, brought into the antechamber. The incision at the limbus was then reopened, and the foreign body was removed by enlarging the incision. So this is something that one can practice using the vacuum and the soft tip cannula to remove foreign bodies like these. A foreign body that is large, one has to enlarge the sclerotomy. This is a 3 millimeter opening. You can see the keratome going in, and you can see that once the foreign body has come out partly, it follows. Behind follows the vitreous along with the foreign body when it is being removed, and it is very important to cut off this vitreous before it is pulled out too much, so lest it causes vitreous base injury. A thorough peripheral examination by indentation at the end of surgery, access to these possible retinal tears is very, very important to prevent a retinal detachment in future. A buckle or band, which is either segmental or an encircling band, has to be used in cases as the case may demand. So in summary, workup localization should be meticulous. There's no single best method. The choice of technique should be individualized based on location, visualization of the foreign body, accessibility of the foreign body, associated pathology like retinal detachment, vitreous hemorrhage, and endophthalmitis. Thank you for your patient listening, and I will be happy to take questions from this point.
Thank you, Guru. Guru, as usual, your videos have shown us various techniques of removal of foreign body. Just because of paucity of time, just hold on, be there online. We'll just finish Dr. Krishnamurthy's talk, and then we'll take some questions in the end.
Right.
Now we'll have vitrectomy for inflammatory RD by Dr. Krishnamurthy. Next video, please.
At the outset, I would like to thank Dr. Ilan and the members of the scientific committee of KOS for making me a part of this wonderful program. Over the next 10 minutes, we will discuss the common inflammatory causes of rheumatogenic retinal detachment and some of the special considerations that we need to keep in mind during surgery for these cases. I'll also share with you 2 videos which elaborate on the steps during the surgery for these cases. One of endogenous endophthalmitis with RD, and another one with acute retinal necrosis and CMV retinitis with RD. Viral retinitis is by far the most common cause of rheumatogenic retinal detachment due to an inflammatory cause. Acute retinal necrosis and cytomegalovirus retinitis are the most common causes of viral retinitis leading to RD. Endophthalmitis with reg RD is another common cause of detachment. Sometimes toxocara granulomas can be associated with retinal detachments. A peripheral vasculitis, which is associated with a tractional or rheumatogenic RD, is quite common. Though the way in which we handle these cases is very much similar to the basic fundamentals of VR surgery, as we have discussed so far, there are certain challenges these cases do throw up, though. For one, there is a very high risk of PVR in these cases. Hence, a complete vitrectomy with a meticulous base dissection is imperative. In toxocara-related retinal detachments, there is often persistent traction and sometimes even retinal foreshortening in the periphery. Hence, dissection needs to be carried out right up to the ora serrata, sometimes even into the pars plana, and occasionally a retinectomy may be required to relieve the retinal foreshortening. The challenges during endophthalmitis include very poor visualization, accompanied by often very severe PVR and areas of retinal necrosis and hemorrhages. Membrane dissection on necrotic retina is always a challenge. In acute retinal necrosis, there is extensive circumferential chorioretinal scarring. Since the disease mainly affects the anterior retina, the scar can extend into the ciliary processes, leading to postoperative hypotony. In CMV retinitis related RDs, the vitreous is thick, layered, and membranous. Often there is a lack of PVD, and PVD needs to be induced during surgery. The atrophic retina is stuck to the chorioretinal scar at places, and hence it needs to be relieved from these chorioretinal scars by retinectomies. This is a case of endogenous endophthalmitis with retinal detachment. Visualization is a challenge. Vitrectomy is completed, and healthy retina is identified and delineated from the necrotic retina and the areas of scarring. Once that is identified, the healthy retina, viable retina, is separated from and isolated from the scars and the diseased necrotic retina so that the viable retina can reattach. Endolaser is done around the edges of the retinotomy. Silicone oil is injected, and we end the surgery with intravitreal antibiotics. The next video is a video which was presented by one of our fellows, Dr. Sneha, in one of the conferences. It deals with retinal detachments caused by acute retinal necrosis as well as CMV retinitis.
Acute retinal necrosis is a devastating disease caused by varicella zoster virus, characterized by retinitis and occlusive vasculitis. Retinal detachment occurs in up to 2/3 of the cases. Chance of redetachment is high in ARN due to ongoing inflammation. Managing such cases is a challenge. Using wide-angle lens, core vitrectomy is done and dense vitreous membranes dissected, giving a clear view of the retina. Spontaneous PVD is common in ARN. Once the retina is relieved of surface membranes, PFCL is injected to settle the posterior pole of the retina. In ARN, it is necessary to dissociate the scarred and the necrotic area from the normal retina, as chance of proliferative vitreoretinopathy is high. The anterior part of the retina is also excised to prevent anterior PVR changes. Endolaser is done to the edge of the retinotomy. Retina is well attached after PFCL gas exchange. Silicone oil is injected. Next video is of the other eye of the same patient. He was managed in a similar manner. This eye had persistent vasculitis with temporal retinal detachment. After co-vitrectomy, PFCL is injected. A relaxing retinotomy is done temporally. Endolaser and gas exchange is done. CMV retinitis occurs in immunocompromised individuals with a CD4 count less than 50. With prompt aggressive systemic and ocular treatment, it can be well controlled. Retinal detachment is a common cause of visual loss in these cases and occurs in the healing phase. In this case, there is a large area of atrophy, temporal and superior to the macula, with subtotal retinal detachment. Core vitrectomy is done. One point to note in CMV retinitis with retinal detachment is that spontaneous PVD rarely occurs, and posterior hyaloid is adherent to the membranes. PVD is induced meticulously. Membranes are dissected transversely to relieve anterior, posterior, and tangential traction. Relaxing retinotomy is done adjacent to the scarred area. As in ARN, it is not mandatory to dissociate the atrophic area from the normal retina, as chance of proliferation is less. Fluid gas exchange is done. Endolaser is done along the relaxing retinotomy, the brakes, and 360 degrees to safeguard the posterior pole. Silicone oil is injected. Surgical outcome is predictable in retinal detachment associated with CMV retinitis as compared to ARN, as inflammation is less and chances of redetachment is low. Thank you for your patient hearing.
Thank you.
Thank you, Krishna, for that wonderful talk highlighting the various types of detachment in inflammatory diseases and how challenging they are. I think we are running short of time as KOS oration is happening in Hall A. I've been asked to wind up this session. I thank all the speakers for their wonderful presentation and participation. And I thank KOS for asking us to run this session. Thank you, one and all. And I'm sorry we did not get time to discuss, in the last two presentations, which were very good. Guru Prasad came out with a variety of foreign bodies that he has managed to remove and highlighted the various techniques. And Krishna showed the challenges in managing retinal detachment due to ARN and CMV retinitis. These are one of the most complex, the most difficult surgeries that we all can perform. And Mahesh and Mugam showed the management of PVR so well, management of ROP so well, and Sunil Ganikal highlighted the various challenges in managing optic pit, associated macular detachment, and Hemant also contributed with the PDR this one. So thank you very much. We close this session. and we see you again sometime in future. Thank you so much.
Thank you,
Thank you, sir.